All right, welcome to our podcast in English. My name is Melvin Bos, physiotherapist, manual therapist, and board member of the Dutch Association for Manual Therapy. This is a special episode where we're now recording in Basel in Switzerland. So it's the first one, I think, from Holland to records outside of the borders. And it's very interesting to talk about pain mechanisms today. There are two guest speakers on this moment for this episode. And first of all, I want to do some introduction for our listeners. So who are the people? And afterward, we're going to talk about the pain mechanisms. So first of all, Morten, can you introduce yourself to our colleagues?
Yes, I can. And apologies for having to speak in English because my Dutch is really non-existing. So.
Normally Danish people are pretty nice with the Dutch language.
Well, I could speak Danish, but I don't think that would make anything easier.
All right, makes sense.
So my name is Morten.
Yeah.
I'm an associate professor at Aalborg University. I was trained as a manual therapist, specialist in sports physiotherapy. I've been a clinician for, I was going to say 25 years, but obviously the last 10-15 years I've been sliding more and more into an academic perspective. But I still see patients, and I think what I do is for trying to understand how we can make things better on a patient level as opposed to an academic level. I guess that's what everyone wants, and me too as well.
All right.
But,
yeah. You did something today as well with the lectures, I think. So that will be nice to talk about as well. But we do it after the introduction. Benoit?
Yes, I'm Benoit Knutsen. I'm not an academic. I'm a manual therapist and primarily a teacher at the Aalborg University of Applied Sciences. So that's my background. All right.
Yeah. Today this is a congress with multiple days, with multiple sessions, and It's very interesting to see the atmosphere around here with all the colleagues from all different kind of nations. So it's pretty fun. But you are doing some lectures as well, Morten. Can you give us a quick view for the listeners? What's the topic?
I was in a session yesterday where we spoke about pain mechanisms. And first of all, what is a pain mechanism? The way we understand pain mechanisms today is a way to conceptualize the connection between what goes on or what changes in the nervous system and how people feel or perceive pain. It didn't always used to be that. There used to be a stronger connection between the physiological processes such as central sensitization, for instance. That was sort of the first real description by Clifford Wolff on what does it mean to have physiological pain, what does it mean to have inflammatory pain, and what is dysfunctional pain, and then neuropathic pain, obviously. But then in 2016, the IASP came out with this new mechanistic descriptor of nociplastic pain. And now the world sort of approach to understanding mechanistic descriptors is that there are nociceptive pain, there is neuropathic pain, and then there's this nociplastic pain. And just to be brief, the nociceptive pain is when there's a stimulus that drives an experience. So there's a primary driver of pain, a primary stimulus that drives the experience of pain. And that could be anything, but the most common condition that we know of would be inflammation. But there could be other things as well. Then we have the neuropathic pain, where there's either a lesion or damage to the nervous system, and that sort of rules out everything else. So essentially that's the one we can use to rule out the others. So clinically speaking, what you would do is try to rule out the lesions or pathologies of the nervous system, and then rule out if there's a stimulus, if there's an inflammation, if there's a pathology going on that could drive nociceptive processes. And if neither of them are present, it would be reasonable to suggest that nociplastic processes are in place, and we can talk about those later.
Thank you very much for this point of view. Very interesting to hear. Benoit, do you want to add something what you hear already from Morten?
So I'm just curious about how this translates into clinical practice and how, especially I guess for manual therapists, how does this apply? How do we use this information in clinic with our patients?
Yeah, I mean, it's a good question. It's definitely a good question, and I'm not sure it does. It really depends. I mean, let's do a case. Let's say there's someone with an inflammatory condition like an acute herniated disc or a fracture or a rupture of muscles. The best thing we can do is to, assess the patient, find out what's going on, making sure that nothing interferes with the process. Many of the things we can do are giving advice and making sure that people don't freak out, making sure they don't fall in despair because of the pain. So there's lots of things we can do, but not per se manual therapy. Because what really needs to do is to leave the body alone and make sure it does what it does best, so healing processes. There's, in my mind, there's no doubt about the pain-relieving effects of manual therapy. They do not work for everyone. They do have between small and moderate effect sizes, and they're short-lived, but that does have a place. So I can see why you could use it if someone is suffering during the process of healing. You could definitely use manual therapy, but I don't see a role where manual therapy changes the healing process. I'd probably rather not see that, to be honest, because I think the body can do that itself. In the case of pathologies in the nervous system, like lesions or pathologies, then it's a bit more difficult to see where manual therapy fits in, but Nina Schmidt is doing some work where it does seem that some of the classical neural tension techniques or neurodynamic techniques might fit in, and that could be part of maybe supporting a rehabilitation process, because even though only, as a broad number, about 20% of neuropathies have neuropathic pain, then for those 20 people, that's a long-lasting, possibly lifelong-lasting chronic pain condition. So anything that could make them self-manage that pain would definitely be worthwhile. And I don't know yet, I don't think anyone knows if manual therapy could play a pivotal role there, but it might. I would probably point more to lifestyle changes, physical activity, sleep, that sort of thing, but I wouldn't discard manual therapy at all.
How do we make that choice of when do we do manual therapy? Is there anything that we can, I don't know, any indications to when manual therapy would be appropriate to use? Or
I mean, there's been some good work trying to find out if we knew the pain mechanism first. So if we understood whether or not there's a nociceptive, neuropathic, or nociplastic pain descriptor going on, would that matter? And it really doesn't. There's not an argument to say that you shouldn't use manual therapy in either case, or you should. It all depends on the person. So by the end of the day, I think manual therapy, at least to me, as a manual therapist with a long-lasting manual therapy background, it's more about communicating and less about adjusting joints or replacing structures or what have you.
This is very good question, Benoit. It was one I once wanted to give Morten as well, but it's very complex, because I think all countries in the world with all the manual therapists are taking this one as a complex situation. Just not only the problem from the patient, but the environment as well, and how to give your role as a manual therapist to the max, So
I put this in there that maybe it's time also to reframe what it means to be a manual therapist.
Redefining.
Instead of being a manual therapist, so working with manual therapy, I mean, the IFOMPT has changed its name, hasn't it, to musculoskeletal. And for me, that process is all about understanding that we are doing patient-centered approaches or patient-centered treatments. So rather than saying, what can I do with manual therapy, we probably want to ask, why would this person benefit from what I have to offer?
Should it be as well with subgrouping or something?
I don't
pre-screening
think so.
or which
Pierre
one?
Kerr, who was just passing us a second ago, has looked into subgrouping, and he was a big proponent, so a big fan of using subgroups, but despite that, there's no evidence to suggest that subgrouping can be better. Just to be fair, because it's not that subgrouping wouldn't work, but if we subgroup 1,000 people into 3 groups, it's not beneficial. But if we subgroup 1,000 people into 990 groups, it might be beneficial.
So
but that's the problem.
It's like the modeling and sizing for the subgrouping is important as well?
Yeah, what we really want to do with subgrouping is finding out who can treat with the same treatment and have better effects. And there's nothing to suggest that that's a strategy that is moving us forward. it might in fact be better to have a more individualized approach and see how does the person in front of me, how do they respond to what I'm doing, whether that be exercises or manual therapy or advice about sleep or daily activities.
How does this affect science? Because we always look at systematic reviews and meta-analysis as the holy grail.
Brilliant question. I think it is disrupting science at the moment. We had the European Pain Federation, EFIC, had a pain school in Krakow last week on translational aspects of pain. How do we do animal models and how does that relate to back pain, for instance? And there are some animal models that have caveats and pitfalls and all of that, but what we really don't have is a good animal model to study nosoplastic pain, for instance. We don't really know how to do it. So where does that take research? Well, essentially, I think what it does, it removes the focus of having to do it in a laboratory first and maybe even shifting it around. That was sort of what we came to on the pain school, is that maybe what we want to do is look more into how clinicians work and what are the problems clinicians see, and even better, partner up with patients and talk to patients about it. What are the problems they experience, and then go back to the laboratory and try to create new models. And I'll give you an example of that. So Safiq Sikandar from England, she's done a brilliant study. She's part of a group, has done a brilliant study where they took neutrophils out of patients with fibromyalgia and put them into mice. And then they could see the mice developed what we believe is widespread pain. So that's definitely within the realms and where basic research functions, but it does give us a model that doesn't have any kind of damage. What you've done is you've changed the setting. There's work to be done also with gut bacteria, for instance. So there's a range of ways now that we could manipulate with animal models so that you can maybe generate something that we believe makes the animal behave not completely like a person, because obviously there will be many things we can't ask animals about, but maybe we can get aspects of what it means to live with chronic pain and study that in an animal. And that potentially could lead to better medication, but it could also help us understand what really happens during manual therapy in these patients. Because manual therapy as a technique or as a group of techniques is probably doing many things, and they might not even do the same thing. So when you, Benoit, is doing manual therapy, it might be different from when I'm doing it, because it probably relates more to what happens in the person. So think of it this way: we don't apply anything to them. We say we do, right? We apply energy or what have you, but really what we want to do is have lasting effects, and the only way we can have that is through the communication and the interaction with that person. So manual therapy can be a way to communicate that interaction and create rapport. I'm taking you seriously, you are worth my time, I'm validating you as a person. This kind of perspective on manual therapy, I think, is less talked about, but definitely not less important.
So I guess that is looking at contextual factors and trying to reinforce how we use the contextual factors.
In
the setting of manual therapy.
But that can be done with anything, right? I think if we want to look at manual therapy specifically, what does it do? I think it creates rapport. It creates that sense of communication. So during COVID, we talked about skin contact, didn't we? And people were hugging trees and what have you. I think manual therapy fits right into that picture of why do we need contact, and what does it mean when a therapist contacts a person and tells this person that I take you seriously, I really want to help you. And if we could differentiate that from the theories of why we apply it, so instead of saying I'm going to test the movement of your joints, maybe say I'm going to see if I can reproduce your pain. And if I do this, does that change? Could you now go back to work versus what could you do before?
So it's the same situation, but a different way of approaching it in your
I would say
communication.
we can use the same tools, but we would probably have to use it, in my mind, in a different
way,
Yeah.
perspective. Is this the biggest chance to achieve as a manual therapist? To getting your communication skills on optimizing it for your patients?
So we do a musculoskeletal Masters of Science in Aalborg University that I teach on, and one of the things that we struggle a bit with, or what our students struggle with, is that on the first 2 semesters of the master's program, they learn to do manual techniques. So for extremities and for the spine, and they learn how to do manual therapy techniques and apply them to the patient and all that. And then on the third semester, we go more into the complex chronic pain conditions. And they struggle to see how does it transfer. So that's what we're really trying to strengthen now is the transfer of these skills as a skill set, a competence, into the biopsychosocial model, for lack of better terms, or a patient-centered approach. And that's not easy, because people, even if we try not to do it, when we teach manual therapy, that what happens is that people think, okay, so these techniques work. So in the case they don't work, I can do something else, I can talk to the person. And in fact, what we're trying to do is say, no, you would always want to listen to the person, you would always try to validate them. And manual therapy is one way to do that. And the better you are with your skills, the better you can do that, the more likely it is that the person in front of you is going to perceive it as something useful.
Very interesting, Morten, to hear. We're at the latest fragment of this podcast, so it's like a final setting, final phase. Is there something, Benoit, you would like to ask as a last question to Morten about this subject?
I had to think about one of the things that David Nichols told in his speech was, you have to learn anatomy, but it doesn't matter. And I think it feels like with manual therapy, we're doing a bit the same thing. You have to learn the skills, but it doesn't matter. But Louis has a good point that he had in Ghent, is if you want to be good at manual therapy, you have to be good at manual therapy. I think it fits in, it's not merely a question, but it fits into what you said, I think.
Yeah, and I think differentiating is good. So you don't need anatomy to be good at manual therapy. I mean, it's definitely one way to teach it, but you could teach it from a neuroscience perspective, you could teach it from a phenomenological perspective, you can teach it in many ways. But it's true that we've bound it up on orthopedic manual therapy, as it was called. So maybe that's what we should change, to say, well, I'm not adjusting joints, I'm not doing anything to anatomical structures. That's the basic science we need to replace, and instead of that, social sciences or philosophy or neuroscience or what have you. That might be interesting at least to do that.
All right. Do you have take-home missions for colleagues?
No, I wouldn't encourage anyone to stop touching people, but I would encourage you to consider, when you do that, are you also telling them that the problem is where you put your hands? Because if you're not going to fix anything, and the patient believes that because you can provoke the pain, let's say in the back, then the problem is in the back, then what are you leaving them with? So I think it's important that we package manual therapy in a way that they understand that what we're trying to do is really to help them go back to work or function as human beings. And manual therapy is merely a method that we can apply that is no better and no worse than talking about sleep or using motor-based interviewing or patient education.
Yeah, I want to do a special thanks to you, Morten, and Benoit as well, for joining this podcast, the very first one on the Congress. So it's a pleasure to have you, both of you, on this location. I would like to do a special thanks to IFOMPT as well for giving us the opportunity as Dutch Association for Manual Therapy to record this one on location. Thanks for listening to this podcast. If you want to know more about IFOMPT, go to the website ifompt.org. If you want to know more about SVOMP, go to svomp.ch. Are you a Dutch colleague and want to know more about the Dutch Association for Manual Therapy? Please visit our website. If you're not a member, become a member. Together we can shape the world of manual therapy. Have a nice day.